Thank you for that wonderful introduction, Maribeth. And thank you for inviting me here. So my name is Vivek. I believe I'm meeting a lot of you for the first time, but I have seen a few of you with Dr. Shapiro in the clinic. I'm a fellow at Albany Medical Center. I'm a second-year fellow. I will graduate next year. So scleroderma is something that I developed interest in after I started my fellowship. And having worked with Dr. Shapiro, having met you guys, my interest has just developed more and more. And I often find that I learn as much from you as I learn from the books. And especially when somebody has been living with it for 20 years, I feel like you know your body better than anybody else could. And often when you would look around, the person sitting next to you would give you better recommendation than I ever could, just because they've had that for such a long time. So I'm hoping that in today's discussion, we can have a discussion instead of me giving a talk. And we can always have more questions at the end as well. If we are running out of the time, I'll be happy to wait at the end too. So in terms of what we'll talk about today, we'll mainly talk about complications that you can expect in the long term. Fortunately, it is true that a lot of complications that you get with scleroderma are early in the disease. It used to be the case that when you look up on internet, all you would see is negative things. And even now, when I have patients who come in for an initial visit, they are very anxious. And the most initial part of our initial consultation goes in talking to them about the new treatments that we have and the new treatments that we are expecting in next coming years. However, when you talk about complications, you have to decide what you are looking at. So scleroderma is in a way a broad disease. So I'm sure most of you are aware that there is limited scleroderma and diffuse scleroderma. So the complications related to them are going to be different as well. Now, there is something that we call overlap syndrome, and like you would expect, it's just overlap between different connective tissue disorders. So now if you were to have it, the complications that you might get might be a little bit of different in terms of what you would expect, what medication you would be on. So very briefly, I'll mention that as well, but that's a completely different topic too. And a little bit about medical medications, especially if you had scleroderma 20 years ago, you might have received medications that we are not even using anymore. For example, we talked a lot about cytoxin or cyclophosphamide. And it's true that we still use it in aggressive disease, but now we have other medications. And it's just not that common, cytoxin. So there are things that you should keep in mind if you received it in the past. Okay. So Dr. Toledo went through this, so I won't spend too much time on it. But mainly we'll be focusing on systemic scleroderma. When we say localized scleroderma, they typically don't affect internal organs. So what should I expect when I've had this for a long time? It truly depends. And the reason being, like I briefly mentioned, that complications are different in terms of types of scleroderma. And those of you who've seen Dr. Shapiro must have heard him talk about different lanes of the road. That there is scleroderma patients who are on the slow lane and might not develop any complications. There are patients who might develop very early complications, and then they would go away. And then there is in-between range as well. Now, a lot of complications also depend on autoantibodies. So you will hear a lot of talk about SCL70 antibody or topoisomerase antibody, RNA polymerase III antibody, anticentromere. The reason being that that is one part of scleroderma, and you can predict some of the complications based on what kind of antibody profile you have. Now, how much internal organ involvement you had when you initially had this also can decide on what kind of complications you might have in the future. For example, if you already had lung damage, unfortunately, that's not something that we can reverse. However, there are medications which we can give you to stop it. and there are ways we can be more comfortable living with it. Again, another question is whether there is an overlap syndrome, if there is anything else that I should keep an eye on. Like we know that there are a lot of genetic foci that have been associated with scleroderma, but they are also seen in other autoimmune disorders, like lupus often has a lot of overlap with scleroderma. So now if you are one of those people who had both of them, then the complications would be different. And then, like we mentioned, the medications. So like I mentioned, the most tangible part about doing rheumatology is getting to meet people like you and hearing the stories. So what I did over the last few days is I, over the phone or personally, talked to a few patients who had this for a long time to see what they've gone through and what they think might be useful to know at this point. So one of the persons that I talked to was diagnosed, or I should say that she started having problems when she was 19. At the age of 19, she noticed that her hands were turning blue, the patriotic color, blue, white, red. She started having itching, and like many of you might have noticed, itching is not something that, we have a medication that can take care of it, and it can be debilitating. She started having problems with her tendon. She was having tendinitis. A year or two later, she got pregnant and started having heartburn. She thought that because she's pregnant, that's likely from that. However, after pregnancy, she noticed that her appearance was changing. The way she looked, the way her face was changing as well. Now you can imagine having this at the age of 20, how hard that can be. Eventually, she did get referred to rheumatology, and she was given diagnosis of scleroderma. At the age of 20, she was very worried. She told me it was one of the toughest times she went through. But now at the age of 55, she's able to do most of her work without any problems. She's able to take care of her daily activities. So my question for her was that at this point, what do you see your challenges? What do you think we can help you with? So her problems are that regular things like going to grocery shopping is hard. As we know that they keep things cold. Your Raynauds get bad. Also, just lifting things is hard because even though your skin thickness tends to get better, you often have contractures. You often still have chronic pain, and that just makes regular things like grocery shopping hard. She was really fatigued, and she was found to have iron deficient. So she had to take iron pills for that. She also told me the way she works around certain things, like Raynaud's, is she uses her remote car starter. She has to make sure that her car is heated before she gets in. One of the complications that she mentioned after having it for years was that she went down to Mexico. And of all the places in Mexico, she developed finger ulcer. Actually, at the airport, she started getting pain in her fingers, developed ulcer, and that was what finger ulcer is something we like to refer as heart attack of the fingers, just because it's so painful, and it can be very serious. You can end up losing finger, so we treat it very emergently. So Raynaud's, and I'll just talk about secondary. Primary Raynaud's can be seen in about 5 to 13% of the patients, but secondary is when it's associated with connective tissue disorder. So often the disease, most commonly it's affecting small arteries, and very often you'll see some pitting in the tip of your fingers. Sometimes you can get superficial ulceration as well, which might not be very painful, but they can still interfere with your daily activities. Like the patient that I talked to, she told me that when she would try to cook or do daily activities, things would get into those small ulcers and irritate her. She found a way around it. She just started using regular gloves instead of heated gloves because the cold wasn't a problem. Things getting inside that was the problem. Now, I wouldn't have thought about it, but now that she told me, I'm sure I'll mention it to my other patients too. Now, often, it can affect a little larger arteries proximally. And when that happens, you can see deep ulcerations on the finger. And those tend to be severely painful. Most of the times when this happens, when you develop these ulcers, there is an inciting factor. Even though it's summer right now, in last couple of months at Albany Med, we've admitted a couple of patients with finger ulcer. Now, Raynaud's, everybody talks about winter months. So why did that happen? Why did that happen in summer? So both of them had inciting factors. Both of them, we could tell that this is what brought it up. One of the patients, because of family issues, she was very anxious, took up smoking, and that was the inciting factor. And another patient also had personal life events, so because of all that stress, she developed the ulcer. Now, once you develop that, treating it may take weeks or months. So you want to make sure that you prevent it. There are a lot of treatment options, a lot of medications, but none of them are going to take care of it overnight. So you have to make sure that you prevent it from happening. So how do you prevent it? I'm sure all of you know about this. You have to keep your ambient temperature warm. Wear layers. Minimize emotional distress. There were some trials about behavior therapy and where they worked with psychotherapists and they were able to control their Raynaud's somewhat. It's not definite. It's definitely not something that I would recommend first line, but everybody has something that they find relaxing. Often people go to church, pray, they find that helpful. Often it's meditation, anything that works for you. There are certain medications that you should avoid if you have secondary Raynaud's. For example, if you have migraines, some of the medications we use for migraines can make this worse because the way they work is they narrow your vessels. And as we know, if your artery gets narrow, that can lead you to have finger ulcers. In terms of when it comes to medications, we often use calcium channel blocker. Amlodipine, nifedipine is something that's commonly used. We also use nitrates. We would often prescribe gel to put on your finger. Then there's a group of medication called phosphodiesterase 5 inhibitor, which is sildenafil or Viagra or Revasio. And there's tadalafil as well. Then there are other medications, IV prostaglandins, statins have been shown to help somewhat. And then is endothelin receptor blocker as well, which tends to help. If you do develop critical digit ischemia and there's medications that outpatient don't work, we typically do have to admit you. Because at that point, we'll be starting you on IV prostaglandin to try and prevent the progression of this. Heparin to thin your blood can be useful, and we would give it to you in the hospital. However, very rarely we would keep it once you get discharged. The reason being, as you know, one of the aspects of scleroderma is it's a vascular disorder, and you are at risk of bleeding. You might have some lesions on your stomach, what we call GAVE, or telangiectasias of the stomach. So that's why we don't prefer chronic anticoagulation. Now, if you have something serious heart problems, then you might require it. So it always comes down to risk versus benefit. And if that doesn't work, we can do sympathectomy. So there are nerves which goes to which are sympathetic nerves, and they are responsible for constriction. So when you are able to block that, that tends to help with the pain. However, often this can be temporary, and with time, it might become ineffective. But in acute setting, it can be really helpful in controlling the pain. Now, before I go any further, anybody has any questions about the Raynaud's phenomena? Do we have anybody who has had scleroderma for 30 years? So if you don't mind sharing, how has your experience been with Raynaud's over the years? You don't have to stand up. I can. Yeah.
Well, you can see my hands have been kind of blue with the air conditioning in here.
Mm-hmm.
And, I've been able to manage it without medication all this time. But just the last year I started taking a small dose, 10 milligrams, and I will probably start, I haven't taken it over the summer, but now that the weather, and air conditioning is one of the hardest things to deal with for the Raynaud's.
Thank you for sharing. So you found also that over the years your Raynaud's got worse. You also found that over the last couple of years your Raynaud has been getting worse?
Well, I'm just concerned more about, it's been the same. It's been the same. It was my first symptom 40 years ago. You know, am I not doing enough? You know, or should I start doing something? I don't want to lose any fingertips, so I've been lucky so far. But I mean, I've had ulcers. I've had, you know.
No, and that's how it typically is. You get some bumps on the road, and sometimes you get better. Sometimes you have episodes where you're getting worse. But I'm glad you're doing better.
Yeah, it can be very painful at times, you know, when I have had ulcers and they've taken a long time to heal, and so I just really think I need to focus more on prevention. That's
very true. Yeah, thank you. So let's talk about a different patient that I talked to over the phone. So when she was 50 years old, she developed pain and tightness all over. She said that she did not think she would ever walk again. She could not get out of the bed. She was seen by different rheumatologists in Albany, in Boston, in Philadelphia. And I'm sure, like many of you know, often it's a process that where they have to find certain things before they can tell you that now we know what it is. Eventually, she got diagnosed with scleroderma. Unfortunately, she did have one of the complications, scleroderma renal crisis. She also developed cardiomyopathy, which is weakness of the heart. Fortunately, she was able to recover through that. And now she's 81, and she told me how she enjoys going golfing with her grandkids. So she's quite active. And this is what she told me, that a lot depends on your attitude. You have to be positive. And that has actually been studied in the literature too, that when they compare people's attitude, that tends to affect the disease as well. So in terms of challenges that she still has, she says that she would get tired easily, and her complaint was she has to see 11 doctors. So that can be hard. And because she was so positive, I had to ask her, like, what did you find most helpful? She told me that the positive attitude with a little bit of stubbornness. When she was very down, she found that her being stubborn helped her. She went to her physical therapy, she went to her occupational therapy, and just pushed herself. And that can be the hardest part, because we meet for half an hour, 1 hour, but there is a lot goes on after that until you come next time to see us or next time we talk. So I wanted to talk a little bit about skin, joints, muscle problems, nerve problems. Most of these problems tend to happen early in the disease, and they do get better with time. Skin changes can happen as well. Skin thickness usually improves with time as well. However, sometimes you develop contractures, and they do not get better. You might feel that your skin is thin, your skin is better. However, I wouldn't say that that skin goes back to normal, because once you had collagen, it often changes the normal texture. So it wouldn't go back to normal, but it would be not just as hard. So you wouldn't have itching, you'd be able to move a little bit more. But when there is contracture, it's always difficult. Often you notice telangiectasia, which tend to get worse with years. People who have centromere antibody or limited cutaneous systemic sclerosis, they would often notice that with years, the telangiectasia is getting worse. And sometimes that can be troubling if there is a lot of them on your face. you might notice it. Unfortunately, there is no definite treatment that we have for it. They've tried using laser treatment, but they can come back after that. So then it becomes an individual decision whether you want to take that risk or not. It has been shown to be associated with pulmonary arterial hypertension. So you would often see us discussing that it seems like your telangiectasia is getting worse. I want to make sure you're not getting any lung problems, and we might be requiring more often breathing tests. So that's where it comes, and that's why we can't have any set protocol that, no, I'm just going to do it every year or every 2 years, because things change. There can be telangiectasia in your stomach too, what we call watermelon stomach or GAVE. That's important because often with years you might notice fatigue, and one of the things we'll check is to make sure you have enough iron. Sometimes you might have small bleeding from your stomach, and your hemoglobin, blood counts might go down, and that will make you feel fatigue. So it's important that we catch for it, because the only way to look for it is with a camera, go in, EGD, and see if you actually have it. Calcinosis tend to get worse with time too. Not everybody would develop it. And unfortunately, there is no definite treatment for calcinosis as if now. There is a trial going on with treprostinil. Hopefully, we'll know about those results soon. There have been some experimental medications like TNF inhibitors, sodium thiosulfide. Sometimes they give it IV or in the lesion that you have. But there is no definite benefit. And sometimes you can do surgery, but you have to make sure that whoever your surgeon is aware of scleroderma, how you would be healing. For example, if there is major calcinosis on your finger joints, it might be limiting your activity. You might not be able to do your daily activities because you can't hold things. In that case, you might need to consider this surgery. And neuropathy is one of the features that tends to happen because there is more swelling, inflammation, which usually happens early in the disease. So most of these nerve problems you would see early. However, they can happen in the late disease too. It's just not that common. Like we mentioned, skin tends to spontaneously thin and keep thinning with time. Contractures, however, can persist. And like this patient that I talked to, the occupation therapy and physical therapy can really help, but it might be painful, and you might find it difficult, to say the least. But there is a really, really good talk by Celeste Freeman, and I've mentioned the web address, but it's on the Scleroderma website, on Scleroderma videos, and she demonstrates the exercises that you can do and which tends to help. So if these are the problems that you are having, I would urge you to at least watch it, and I'm sure you will find it useful. There's also been studies using paraffin wax bath, where they heat it at 50 degrees Celsius. So I think that's about 120 to 130 Fahrenheit. So you want your paraffin wax to be hot, and then when you put your hand on it for some time, it has been shown to help you with the pain and inflammation. It has also been shown to improve the joint motion and skin stiffness. They've also done a trial showing massage and joint manipulation of hand, which showed improvement in the fist closure, hand motion, and hand function, and quality of life. So even improving it a little bit can really help you with your daily activities. So these are the things that you might find really useful in terms of your daily life. Scleroderma and kidneys. So kidneys are involved in about 20% of the patients. They typically happen within first 5 years. So I wouldn't go in more detail about it. Dr. Toledo talked about it a little bit. However, we are investigating right now late onset renal crisis. In the international conference that we had in Pittsburgh, we talked to a couple of other people from Johns Hopkins, Pittsburgh, and they have also noticed this phenomena that when things change, sometimes these things which are supposed to happen early can happen late as well. So for example, if you were to develop any heart complication and you don't have enough blood supply to kidneys, that might be one of the precipitating factor. We will be investigating it further, so I can't say anything for definite that we know why that happens, but that's something to keep in mind. The main thing is to make sure that you detect and treat early, check your blood pressure at home. If it's elevated, call your doctor. Group of medication called ACE inhibitor, captopril and enalapril, has really changed the outcome of kidney disease in scleroderma. However, it does not prevent the renal crisis. In the one trial that they saw, they did not find that it prevents it. However, if you were to develop it, it really helps you in terms of preventing you from going into renal failure. Now, if you were to go on dialysis because of renal failure, even then, 50% of the people can come off of it. And they've seen that up to 2 years, you are able to get your renal function back, which is unusual because that does not happen in other disorders. And they've seen that if you end up on dialysis, kidney transplant has good outcomes as well. So this is just one of the slides. It's from 1994, so it's old data, but it still shows you how things changed once we started using ACE inhibitor medications, where the mortality used to be really high, and it completely changed it. We think that there is still room to improve it. We hope that nobody has ever to go into dialysis because it's just hard going to dialysis 3 times a week. So we'll be investigating this further, and hopefully things will change in coming years. Any questions about any of this? Now, anybody here who's had scleroderma for 20 years? Okay. Anybody would like to share how you think your scleroderma changed over the years?
I was 51 when I was diagnosed. It took about 7 months. And then I had the good fortune to go to Dr. Mehta in Pittsburgh. And I'm now 75, so I've lived 24 years. I have to say I feel very indebted to him because at the time he was still using deconserving. And I did talk Dr. Shapiro into keeping me on for 17. So I really haven't been off it. I think it became more of a placebo. I'm not quite sure why they took it up. I guess they found other things that were better, but for me, it was a miracle drug. Because I was pretty severe when I was there. I didn't know what was happening like everybody else, but I did have hand therapy for 2 years, which made a huge difference. And I just stayed very active physically as much as I could, and it came back. And, 8 grandchildren later, I've been most fortunate that I've been able to, I'm still enjoying it. But I do think you have, if you can, stay physically active, I think mentally, it really helps tremendously. And I'm sure most of you have support in your family, which is also huge. So it's kind of a combination. But I'm very grateful.
No, thank you for sharing that story. I met Dr. Metzger in Pittsburgh because this time International Conference was in Pittsburgh, and he gave the main talk. So it was very inspiring. He just stopped seeing patients. But yeah, they used to use penicillamine. And I was talking to him after his talk, and he told me that back in the day, they used to give just a handful of aspirin and say that when you get ringing in your ears, call me. And then they would just decrease the dose. But that tells you how things have changed, because nobody's going to use aspirin. And I doubt anybody else has even used penicillamine. They used to use it, and there have been reports that it worked well. But I think we've stopped using it now completely. So this is another patient that I talked with. She was a 40-year-old female when she developed shortness of breath, fatigue, She was evaluated for pneumonia, and after X-ray, she was told she may have cancer. Fortunately, her primary care did complete examination and saw that her skin was really thick. So she checked some blood work and found that her ANA was positive, sent to rheumatologist. And that's how they found out that she has scleroderma. So you can see how everybody, and I'm sure you'll say the same thing, everybody has different story. Everybody finds it out in a different way. The thing she told me that she was really frustrated when she got diagnosed just because she did not know what was going on. Because she didn't know what was better, cancer or scleroderma, because she couldn't find any information about scleroderma at that time. So over the years, she developed finger ulcers, reflux symptoms, more GI complaints. But now, at age of 60, she is also playing golf. So I think there is some correlation between scleroderma and golf. But she's able to do it without much. Yeah. So she's able to do most of her activities without any problems. When I asked her about her challenges, she told me about acid reflux, and she keeps getting pneumonia, which really bothers her. Because I'm sure if you've ever been admitted to the hospital, it's just a different experience. Being in that role is not something any of us want. And fatigue, like most of our patients tell us, fatigue is the biggest complaint they would have. So let's talk a little bit about GI symptoms. So scleroderma is something that can affect you from the top to the bottom in different ways. So you have to be very careful when you examine and when you're evaluating, because the problems can be at different levels. There was this one study in 2010 where they evaluated the symptoms, and one of the most common things was acid reflux. And I think most of you would agree that acid reflux is one of the commonest thing that patients with scleroderma go through. Abdominal distension, bloating, constipation, diarrhea are common as well. And we often don't talk about this, but this is very important emotional and social issues which comes along with scleroderma. So when you talk about mouth, one of the major things is, when you've had skin thickening around your mouth, it's hard to open it completely. And it really becomes a problem when you go to a dentist who's not used to treating patients with scleroderma or what to expect. There is a really good information, again, on the foundation website about dental care. And for somebody who's had it for 20 years, I think you can probably educate them regarding what you have and how that affects you. You can see that gums are affected often. Often they'll have dry mouth. That's one of the most common complaints that comes along with scleroderma too. Acid reflux. Lifestyle changes are the main thing to keep in mind for this. They've shown that they can be just as good as medication. However, most of the times we will use medications, most commonly proton pump inhibitors, which I'll talk about it briefly in the later as well. And there are medications which we can give you so that, which are called prokinetic. Basically, they help you go things down, so they improve the contractions of your GI tract. One of the complications we are always afraid of is Barrett's esophagus. Basically, when you keep getting reflux for a long time, the cells of the lower esophagus can change. And when you see that change, it's very concerning. The reason being they are considered pre-malignant, and they can develop into cancer. So that's why we are really careful in terms of treating GERD. We really want to make sure that we keep it under control. Often, one of the most common complaints that we would hear is dysphagia, or problem swallowing. That also comes because of ineffective contractions, so you're not able to swallow it properly. So you have to make sure you take small portions, you chew your food properly. Sometimes, even then, it's hard to eat, and then you might have to go in, or you might have to do some scan to make sure you don't have any strictures, which can contribute to you having dysphagia. If this keeps happening, sometimes you can develop ulcers. Sometimes you can have spasms, which are really painful and can feel like you are having a heart attack. The treatment is similar to heart attack in terms of nitrate group of medication tend to help with this too. And we mentioned Barrett's esophagus. Coming to the stomach, when it can't contract properly, may lead you to feeling full early on. You might not be able to eat as much. You might get more nauseous, and it can contribute to your reflux getting worse. Sometimes you can have chronic pain in your abdomen as well. Watermelon stomach, I mentioned briefly, which is basically vascular disorder of your stomach, often can lead to bleeding and cause you to have anemia. You can develop ulcers and inflammation in your stomach as well, what we call gastritis or gastric ulcer. You can have bloating, constipation, cramping. Constipation makes sense because you're not contracting properly, but sometimes opposite to that, you can have diarrhea, which is mainly because when you're not contracting properly, there can be overgrowth of bacteria, like Dr. Raynaud mentioned. And we typically treat this with cyclic antibiotics. Now, I wanted to mention briefly about diet as well, because I've had more questions about this when I'm talking to you guys in the clinic. So in this one of the trials, they showed that celiac disease can be seen along with scleroderma. In this particular study, they took 52 patients, and out of them, 6 patients were positive for blood test that we do for celiac. And when they did EGD through the scope, 4 of them were positive for it. And when we see undifferentiated connective tissue disorder, that typically means that you don't set in particular criteria, but you might develop scleroderma or lupus later. And when they looked at those patients, 83% of those patients showed scleroderma-like symptoms. So obviously, if you have celiac, avoiding gluten is going to help you. However, there has been more interest about this entity, what we call non-celiac gluten sensitivity as well, where you wouldn't taste positive in terms of your blood work. However, you can have stomach problems, and you can have other problems similar to celiac. So the problem is that we don't have any definite diagnostic test for that. So then it comes down to trial of going gluten-free and see if that helps you. And I just saw a patient past week who went off gluten, and even though blood work was negative, he was feeling completely different when he came back after 3 months. And this is one diet that we often talk about. It's called FODMAP diet. That was developed mainly for IBS patients. But a lot of our symptoms with scleroderma are similar to IBS as well. And as far as I'm aware, I don't think it has been properly studied in scleroderma. But when I talk to patients, they often find this useful. Basically, you reduce amount of high fructose food, wheat, onion, and substitution with wheat-free and other low-fructose alternatives. Reduction in high galacto-oligosaccharide foods like chickpeas and lentils, reduction in high polyol foods, and avoid polyol-sweetened sources, and replace it with suitable fruits and vegetables. And in patients with lactose malabsorption, reduction in lactose foods tends to help as well. So I know it's a lot, but there is a website, which I mentioned below. So Stanford University has a good handout about it, if this is something that would interest you. So I won't go into too much detail about lungs, because interstitial lung disease tends to affect early in the disorder. However, I would mention that when you have interstitial lung disease, sometimes you would be on treatment, and after years, the question comes, now, what do I do after this? When do I stop it? When do I cut back? I do not have a clear answer for that. However, we have seen, so cyclophosphamide study, that was Scleroderma and Lungs study 1, they saw that with Cytoxan, lung function stabilized. But once it was stopped in few months, the improvement that you had got went away. CellCept they found useful as well. I was talking to Dr. Shapiro, and he mentioned that when he tried on a couple of patients to stop CellCept, unfortunately, the lung symptoms got worse. So it's going to come down to risk versus benefit until we can get a definite answer regarding this. Pulmonary hypertension, we mentioned briefly, is one of the things that we closely monitor with years. The way we monitor it is through breathing test. And when I did my medicine residency, I used to work in a pulmonary clinic, so I know they can be hard. And the people who do it tend to have certain personalities. I used to hear a lot of yelling. But they are the things, they really help us right now in predicting whether you need further testing or not. We check what we call FVC, or forced vital capacity, and DLCO, which is diffusion capacity of carbon monoxide. And they've shown that those trends can predict your development. Because the way to confirm this is through a catheterization. So that tends to be invasive. So you would like to avoid it if you don't need it. However, if your PFT is abnormal, you would often see your doctor ordering echocardiogram. And in echocardiogram, we'll look at the pressure. If they are high, now echocardiogram is sensitive. That means it's able to catch a lot of things, but it's not specific. That means that we can't say for 100 very surely that that's what you have. So then we'll have to go and make sure that we do a cath before we start you on definite treatment. So now, talking briefly about the heart. So I just want to make sure that I discuss a little bit about the anatomy of heart, because when I'm going to talk about pericardium, it's the outermost layer of the heart, so this part. And you see there is some space in between this. So that's pericardial cavity. So you might have some fluid inside that, and that's what we mean when we say pericardial effusion. So that's fluid in that cavity. And then sometimes you can have this involvement of this muscle, what we call myocardium. And this is the endocardium, innermost part of your heart. A lot of current that goes through your heart goes through this innermost part. So if that's affected, that current cannot go through normally, and you might develop irregular heartbeat, or what we call arrhythmias. So fluid around the heart, or pericardial effusion, is actually more common than you would expect. I suspect that not a lot of you would have had problem with that. We've had patients in the hospital who needed surgery for it, but that's not very common. However, if you were to do a random echocardiograms, ultrasounds, you would see fluid more commonly than you would expect. Sometimes the muscle layer can have fibrosis too, and when that becomes thickened, it interferes with the contracting capabilities of the heart. And like I mentioned, sometimes you can have arrhythmia when the innermost layer of the heart is affected. Now, in terms of atherosclerosis, what all of us get to some extent as we age, the data regarding it is controversial. Some people say that it's actually not worse compared to people who don't have scleroderma, but then there have been some data saying that no, it's more. So I can't give you a definite answer regarding which one is right. However, we do know that there is microvascular disease. So there is small vessels. Normally when you think of heart attack, you think of coronary arteries, which are relatively larger. But in scleroderma, you can have small vessels affecting your heart too. And in coronary arteries, often when you do cath, you'll find it normal, but then you're having chest pains, you're having all the symptoms of heart attack. So they've shown that sometimes those arteries around your heart spasm too, just like in Raynaud, and that would cause you similar symptoms. Heart failure tends to happen with time as well, typically because it's fibrosis of your heart layer. It tends to be diastolic. There are two types, systolic and diastolic. Basically, diastolic means you can't relax it properly. Systolic, you can't contract it properly. So in scleroderma, we tend to see diastolic more commonly. And sometimes you get cardiomyopathy as well, which is weakness of all around your muscle. And that can happen with scleroderma, but it's more common when you have myositis along with scleroderma, which unfortunately that overlap is actually quite common. And when you develop myositis, that's something that we'll be focusing on. Now, mentioning briefly osteoporosis, it's seen in about 3 to 51% of patients with scleroderma. And one of the studies showed that it might be more common compared to people without scleroderma. The things to keep in mind when it comes to treatment of osteoporosis is often, as first line, people will use medication Fosamax, also known as alendronate. If any of you have used it, they tend to be quite big pills. And as we know, most of our patients with scleroderma tend to suffer from GI issues, stomach issues. And they can get stuck there. They can cause you to trouble ulcers. So I know Dr. Shapiro tends to avoid it. I know some people would use it, but would be very cautious with it. Prolia, there is no official information about this, but we've seen a couple of people. So Prolia is technically a biologic kind of a drug, and sometimes it can activate your scleroderma. So that's something to keep in mind on. And vitamin D, I brought it up because I did one project with Dr. Shapiro where we showed that there are two forms of vitamin D when you talk of vitamin D. There is 25-hydroxy, there is 125-dihydroxy. And there might be some discrepancy between that. So if you keep having low vitamin D, you should make sure that the activating form, 125, is checked, just so that, because we've had a couple of patients who got hypercalcemic because they kept getting high doses of vitamin D, and they weren't technically vitamin D deficient. Now, one thing that affects a lot of people, but we don't often talk about, is sexual dysfunction in scleroderma. Fatigue is one of the most common symptoms and can certainly affect, can certainly be a part of this. However, in women, often you would have vaginal dryness, which can be because of scleroderma, but it should be kept in mind that scleroderma tends to affect around menopausal years. So you want to make sure it's not because of low estrogen, because then giving that can help you with it. Sometimes you can have Sjogren's syndrome, which typically dries out your mucosa, and that can be a part of it. Joint pains, chronic pain is a part of scleroderma, and that can interfere with sexual activities. And like we briefly mentioned, emotional and psychological issues are a big part of it. In men, a lot of GI issues have been shown to affect sexual activity as well. Erectile dysfunction can be due to neurological cause, where now affecting the cause of erectile dysfunction. And sometimes it's medication, like calcium channel blocker. So it's something that should always be checked, because if that's the case, it's something that's easily reversible. So this was one of the studies where they showed patients with sexual problems, what kind of difficulties they thought they had. So you can see that there was a lot of body pain, fatigue, vaginal discomfort, vaginal dryness. So if any of that are issues, that's something that can be easily controlled. So it's something that should be brought up. And there was one trial asking about the source of emotional distress. Often, like we discussed, just getting diagnosed, knowing that that's a new condition that you will be living with can be cause of a great distress. You can have daily struggles, like we mentioned, going to grocery shopping, just being anywhere where it's a little bit cold can remind you of the problems that you have in your daily life. Often people find it hard to do their daily work. Employment and financial burden is a big problem as well, because scleroderma can affect you very aggressively, and you might find yourself in a matter of weeks that you're not able to do your daily activities. Sometimes, typically when it affects men, I saw this one flyer about scleroderma support group for men, which is great, because we always think of scleroderma as a disease of women because it affects 80% of women. But that changing family roles, or even for women not being able to do their work at house, can be a big factor in terms of their emotional distress. The regular social interaction can be affected as well. One patient I talked to, she told me her whole story. She was very nice, but she did tell me that she tries not to talk about scleroderma with other patients just because it reminds her of her worst time when she had the main problems. She's doing really good now. She's doing really well. And then navigating the healthcare system. I'm really glad that we are having this meeting and we have such a great support group. But that can be a challenge because a couple of weeks ago when I saw a patient with digital ischemia, she hadn't seen a doctor for 15 years. She was just discouraged when she got diagnosed with scleroderma, didn't see anyone, and then she ended up having heart attack of her fingers. I won't go into detail, but these are some of the overlap syndromes that you can expect. What we call mixed connective tissue disorder is basically a combination of scleroderma, lupus, myositis. So in that case, we'll be thinking about those things. There can be polymyositis, which is actually very common. And there is an antibody called PMSCL, which can be seen with this patient as well. They can have significant muscle weakness. There is overlap between rheumatoid arthritis, so they can have synovitis, which is swelling and tender joints. Overlap of lupus, and actually overlap with Sjogren's is quite common too. Just briefly, medications. So cyclophosphamide, we discussed. We used to use it more commonly. We still use it. It's a life-saving medication. However, it does carry a risk of bladder cancer, 5%. So you would see often once you received it, your doctor will be checking your urine periodically, because if there is any blood in your urine, we'll be referring you to a urologist. Catching it early makes it very treatable, but you want to make sure that that's something that's followed if you receive this medication. There is increased risk of other kind of cancers as well, so you want to be up to date with your cancer screening. And if this is given in young patients, there can be gonadal failure, so so you might not be able to conceive once you received it. However, it all depends on how much dose you were given, how young you were when you received it. So there are a lot of variables, but that's something to keep in mind when you are having this discussion. And proton pump inhibitors, there is a lot of information out there, which can be scary when you read about all the information. However, make sure you discuss with your doctor, because like I said, if you don't treat reflux, it can lead to Barrett's esophagus, which can lead to cancer as well. So these are all the I'm sure you heard of these names. There are medications available over the counter too, omeprazole, lansoprazole. If you're using it over the counter and needing it for more than 2 weeks, you should really be talking to the doctor as well. Proton pump inhibitors have been shown to decrease your absorption of calcium. So if you are requiring calcium, you want to make sure that you take calcium citrate. There are two forms commonly used, calcium carbonate and calcium citrate. So citrate form does not interfere with omeprazole or any PPIs. Then it can interfere with vitamin B12 absorption too. So that can be one cause of you developing anemia, weakness. If you are really deficient in vitamin B12, it can affect your nerves too. It can affect with absorption of iron, magnesium. So that can contribute to your weakness. There have been some studies that taking this medication can increase your risk of infections because it changes the gut flora. So you can have higher risk of pneumonia, infections like Salmonella, Shigella, C. diff. There has been some association between kidney problems and proton pump inhibitors too. Prednisone is commonly used. Main thing to keep in mind is often you will hear that you shouldn't take high dose of prednisone. The reason being that once prednisone 15 or more milligrams has been associated with scleroderma renal crisis, so we tend to avoid it. There are times when we don't have any options and we might have to use it. But even keeping that aside, prednisone is a risk factor for weakening your bones. You may develop osteoporosis. It can get you a vascular necrosis, fractures of your bone, blood sugar problems, blood pressure problems. So those are the things, some things to keep in mind. I know it's a lot and I can't cover all the medications, but I just wanted to bring it up so that if this is something that you are on, you can have those discussions in your visits. Okay, thank you so much.